Excellent. Well, thank you so much, Helen, and thank you, Benjamin, as well, for having me here. And I'm excited to speak to the BANT audience. Nutritional therapists have a really important role in thinking about functionality and performance of the body rather than waiting for certain pathologies. And that is the root idea around functional liver health, right? So and I'll jump into that in a second. So these are all my disclosures, the companies I founded and I'm part of, and companies that I'm advising. So, what is functional liver health? So, the whole idea here is going from pathology to performance. What does that actually mean? Well, pathology normally, when we're looking at liver and liver function, the pathology aspect of it is rooted in identifying, sorry, just minimizing something, rooted in identifying enzymes, so elevated enzymes or dysfunction through measuring enzymes, so ALT, AST, for example, and then also looking at steatosis, right, which is the accumulation of fat on the hepatocytes, on the liver cells, and then steatohepatitis, which is would be the next step, which is now you've got accumulation of fat and you've got damage to the liver cells, and then that, of course, progresses to fibrosis, which is the laying down of the fibroids, and then finally, once the liver gets damaged enough, it gets to a point where it can't recover anymore. Then you go into the process of cirrhosis. So there is a pathology there that is most commonly used to identify liver health. But I think what's more important is much earlier detection of liver performance. And part of the reason why it's important of identifying liver performance is because the central role that the liver plays in all different aspects of our health, right? So the functional liver health reframes liver's evaluation from this focus on what's happening with the pathologies and structural changes to this dynamic model of, is the liver performing? How resilient is the liver? What is the adaptability of the liver? And how does it impact other functionalities, right? Because remember, the liver is a regulatory hub sitting in the middle of numerous important functionalities within the body. The liver connects and regulates core systems like your metabolism, right? And we'll talk a bunch about the metabolism here. Endocrine signaling, both sex hormones, non-sex hormones, so metabolic hormones and so on. Immune tolerance, it plays a big role in the immune system, and tolerance associated with the immune system. It impacts the gut microbiome in a significant way, and the gut microbiome impacts the liver right back. We'll talk about some of those connections. And it serves as a systemic homeostasis hub, right? When the liver is underperforming, numerous systems start to fall apart, and the earliest detection of disruption in those systems can be seen in liver performance tests, right? So I think it's really important, and I think we are often overlooking the liver as a core component of holistic health, functional medicine, and looking at root cause drivers within common dysfunctions. Core strategy here is to optimize the liver before damage can occur, right? Remember, steatosis is early signs that damage may occur. Steatohepatitis, which can be NAFLD or just NASH, or now it's called MASH. I think it's metabolic associated steatohepatitis. We don't want that damage to occur, and in fact, the liver's performance starts to suffer well before you see that, right? So we want this functional intervention that is aimed to really optimize the liver's regulation and functionality before any sort of structural damage or any sort of functional reduction can be seen in the liver itself. So this is the concept around functional liver health. Now, I mentioned enzymes, right? So again, enzymes, you can do serum tests. It's a normal part of a CBC or CMP. Certainly, the way we do it here in the States. Liver function tests are often associated with the enzymes, but enzymes are a total miss in understanding early dysfunction, right? Because ALT and AST are lagging indicators of liver dysfunction, right? So these traditional liver enzymes, the ALT and AST, only start to rise after hepatocyte injury has occurred, right? Missing early dysfunction stages. And so, we see it here all the time with clinicians and doctors where they go, is the patient's, where you ask, is the patient's liver doing okay? And they go, yeah, their AST, ALT is normal, GGT is normal. Well, that's not enough to know that, right? Because ALT and AST are lagging indicators. Early stress is mitochondrial and signaling based, right? And this initial liver dysfunction often starts with some form of mitochondrial stress and altered bile receptor signaling, right? Which then alters a number of systems in the body that can actually be measured. So this FXR TGR5 signaling and disruptions in that signaling can be measured early and is one of the earliest dysfunctions to occur when the liver starts underperforming as a result of mitochondrial and oxidative and inflammatory stress. And the dysfunction in the FXR TGR5 system actually will lead to all kinds of other symptoms and measurable biomarker changes and health concerns outside of the liver. And we'll illustrate what some of those are so that you could see and get an understanding of how you can measure FXR TGR5 function using surrogate markers, right, of metabolism and so on. So we'll unpack all of that for you. And upstream functional markers are needed, right, because you're not going to typically measure the direct impact of FXR TGR5 dysfunction, which will be on markers like FGF 19 and 21. Those are going to be tough, but you can look at it in terms of fasting insulin, LBP, which is LPS binding protein. These things can detect underperformance in an earlier stage rather than the conventional labs can, right? And I'll unpack what LBP is and all that and how it relates to the issue of functional liver tests. So the normal progression from function to dysfunction is you have, for functional liver, you've got mitochondrial and oxidative and other stress. This is the reversible zone of liver damage. Then the next thing is you may get some enzyme elevation, and then structural damage occurs finally, right? And once structural damage occurs, as you see in late stages of steatohepatitis, and then of course early stages of fibrosis, then you can't reverse that damage anymore. And so the conventional view is looking at liver enzymes where you're trying to detect dysfunction and trying to catch early stages of structural damage. The problem with that is it is a lagging indicator, and so it's gone too far. What we really want to look at, if we really are thinking about the liver from a functional perspective, we want to indicate early on in the mitochondrial stress phase, right? Which means looking at the functionality of the liver, what systems it impacts, and therefore what biomarkers can we detect earlier on to understand liver dysfunction, right? And again, just to put an even finer point on liver enzymes alone, they themselves don't tell the story, because in fact you can have quite a significant amount of dysfunction and damage in the liver before the enzymes even elevate, right? So here's a couple of examples here where you can have normal LFT, so normal liver function tests, right? But your patient can still be quite dysfunctional, right? So monitoring the liver enzymes doesn't necessarily help. So here are a couple of studies. This is a systemic review that found that patients with chronic hepatitis B, right? So obviously they've got pretty active and progressive liver dysfunction and damage, can have significant hepatic fibrosis even while their ALT levels are within the normal range, right? So they've gone all the way to fibrosis level. So that means they've gone beyond steatosis, beyond steatohepatitis, and they're entering early stages of fibrosis, and still their ALT is normal, right? So this suggests that ALT alone is not a reliable marker, as was concluded by these researchers. Here's another one on metabolic syndrome and normal liver enzymes, right? A case control study found that individuals with metabolic syndrome had an increased risk of liver dysfunction, even when liver enzymes were within the normal range. So this clearly implies that liver function tests may not fully capture the liver stress in these conditions. And metabolic dysfunction is one of those key areas where liver performance will be a major deciding factor in the progression of metabolic syndrome in that individual, right? And we'll unpack that a little bit. So early detection in metabolic syndrome and metabolic dysfunction becomes really important. And so if you're looking at liver enzymes to understand the liver's role in the process, then you're going to be missing out because the liver enzymes can remain normal for some time. And all of this to me also says that our reference ranges for liver enzymes are completely off, right? Just taking massive cohorts of, really young, healthy people mixed with older people and all that. I mean, this is where we're creating these reference ranges, right? So they're not really servicing patients really well. Here's another example, liver disease in HBV and HCV. Another study highlighted that significant hepatic necroinflammation and fibrosis may be present in hepatitis B and C virus carriers, as well as in patients with non-alcoholic fatty liver disease, despite persistent normal ALT levels, right? Imagine fatty liver disease, hepatitis B, hepatitis C, and ALT levels are still normal, right? And this also in part speaks to the resilience of the liver, right? It's one of the only organs that can heal itself and regenerate itself up to a certain point. And so it keeps performing in one way or the other. And so the enzyme detection is not really telling us a story. Where we will see the stories and the markers and the surrogate markers and the systems biology approach that I'm going to share with you in the upcoming slides. So defining functional liver health again, we have to look at it as a multi-domain functionality. So functional liver health will span metabolic health, right, through metabolic buffering, immune tolerance and its role in the immune system itself, its symbiosis with the microbial environment. The microbes in the gut play a very important role in feedback loops of the liver and function of the liver, and thereby the liver also plays a very important role in the function and ecosystem of the microbial community, and then of course endocrine processing as well. The bile FXR TGR5 signaling, excuse me, is a really, really important component of the regulatory function of the liver. Bile acids are way more than detergents, right? We often think of them as detergents as ways of emulsifying fat-based nutrients to get them across the lining of the gut, get them into enterohepatic circulation, get them to the liver so that they can be metabolized within the liver itself. Obviously, we need bile for that. That is a key important function of bile, but bile is a lot more of a signaling molecule than we give it credit for, and thereby the amount and functionality of bile becomes really, really important in understanding liver performance, right? And I'll in an upcoming slide, I'll really break down what this FXR TGR5 receptor complex does and how that regulates a number of systems. But what I can say now is that it impacts everything. It impacts everything from metabolism. It impacts everything from insulin response and glucose control, lipid metabolism, and then immune response as well. Of course, it also impacts GLP-1 and GLP-1 release from L cells in the gut itself. And then it's a feedback loop for how much bile is going to continue to be produced, and that is through the regulation of the CYP. It's CYP 7A1 system. So we'll double click on that and we'll define that in an upcoming slide. Another important thing here to understand is pattern-based assessment becomes the more profound way to look at liver function and performance, right? So effective evaluation will rely on this idea of interpreting biomarker patterns across different systems because the liver is a hub. And as a hub, it impacts multiple systems. And what you really want to understand is looking at patterns of performance issues across multiple systems to understand where the liver is in its performance capability, right? So we'll again unpack some of that as we look at some of the target biomarkers and the surrogate biomarkers that you can start to think about when you're thinking about liver health. So the systems integration model. For the systems integration model, the idea is that the liver isn't operating in isolation, right? And I still hear this certainly in allopathic medicine, definitely less in holistic and functional medicine, where the view of the liver is that it's a filter. Right, it's just filtering everything. It's detoxifying, and so it's cleaning up things that are coming in, and it's cleaning up blood, and so on. And as a filter, it's operating independently on its own. Well, we know it's not, right? We have the gut-liver axis, the enterohepatic loop, which recycles bile acids. It detoxifies microbial byproducts like lipopolysaccharide, which I'll touch on in a upcoming slide, and then it directly affects gut integrity as a result of that, right? So much of the integrity of the gut lining and the microbiome itself is dependent on the liver. We also have the liver endocrine axis, right, which shows that the liver regulates estrogen clearance. We also know that T4 to T3 conversion is impacted heavily by the liver. We also know that SHBG, sex hormone binding globulin synthesis, is controlled by the liver. And then integration of all hormone signaling occurs through the liver as well. So there's a massive endocrine loop within the liver's functionality as well. And then the liver also affects the brain, right? We have the liver-brain axis, where liver processes things like ammonia and kynurenine, which affects tryptophan metabolism, and it can send metabolic signals via bile acids and FGF21, which can influence mood and cognition quite a bit, right? So looking at this systems integration model of the liver helps us identify that the liver is not functioning in isolation, that the liver impacts virtually every other system in the body. And as a result of that, when you have issues in any of these systems within the body, you then also have to assess the liver for its functionality, right? And even in holistic health, I often see the liver being ignored, right? Like if somebody is having a cognitive issue, right? So anxiety, stress, maybe brain fog, right? How often are we looking at the liver as a potential root cause driver of that, right? If somebody's having gut issues, if they're dealing with leaky gut or SIBO, how often are we looking at the liver as a potential core driver of the problem, a root cause driver of the problem, right? For perimenopausal women, of course, right? When estrogen becomes dysfunctional, or hormone imbalances ensue, or even prior to that, anyone with estrogen dominance, how often are we looking at the role of the liver in these conditions? And so this is the frame shift that we need to have a little bit, given that the liver is a hub in a systems integration model. For all of these types of conditions and issues, we have to start looking at the liver as a potential root cause and assessing performance of the liver as well. So early intervention then provides us significant opportunity to help many of these conditions even before they progress, right, in any significant way. So this pathology prevention issue is critical when we start to look at functional liver shifts, right? Because the shifts in the functionality of the liver occurs way before any pathology changes, and so thereby, if we're detecting functionality, it gives us this window for intervention with diet, nutrition, and lifestyle. And I'll, of course, provide some suggestions of some of the things that can move the needle on the liver function itself. Tracking upstream markers, right? So these are some of the markers that you can start to look at from a liver function perspective. And again, none of these markers on their own is going to be indicative of dysfunction in the liver. It's going to be looking at a pattern among all of these markers, right? So fasting insulin is a really important one, and we'll explain the mechanisms by which these markers become important, right? But fasting insulin, the triglyceride to HDL ratio, ApoB, and ApoB even more so than LDLC, or at least congruent with LDLC, HDL3, which is a derivative of HDL, the high density lipoproteins, LBP, which is LPS binding protein, and then FGF19 or 21. These can all reveal early dysregulation, and we'll talk about the patterns there. So prevention is going to be greater than repair. Timely action using diet, exercise, and supplementation can restore function and prevent all of this types of structural damage that may occur down the road, right? So this is the opportunity to look for early dysfunction in the liver, which is completely reversible because the liver is really quite robust in this manner. So let's now, over the next few slides, we're going to look at critical functions of the liver, and then therapeutic targets for functional liver practitioners, right? So we'll look at, metabolism, we'll look at gut function, we'll look at brain function and hormone balance as well. And if you're dealing with, patients or clients that are dealing with any of these issues, categories of issues, you have to start looking at the liver as well, right? And start to understand patterns, and especially if they have issues across these systems, right? If they have a gut issue and a brain issue, then the liver is playing a central role between the two, right? If they have a gut issue and a metabolic issue, if they have insulin resistance and SIBO at the same time, or insulin resistance and just severe dysbiosis, right? Like food intolerances, like bloating, distension, and so on, then the liver is absolutely involved, and liver dysfunction is absolutely involved. If they have significant hormone imbalances, if they have an elevation in estrogen, so they have estrogen dominance, and they have metabolic issues, and they have gut issues like SIBO, these are all, it's not uncommon at all to have patients or clients with multiple issues across these systems. And often the liver and the liver's dysfunction is driving risk for having this multi-system dysfunction, right? So we'll talk about that. One of the first ways in order that you could detect dysfunction among the liver is looking at hepatic glucose regulation and insulin sensitivity, right? So insulin will modulate hepatic glucose output. We know that, but then the liver regulates fasting glucose, and it does so via insulin signaling and hepatokines like the FGF21, right? So this and the FGF21, these hepatokines enhance insulin sensitivity. So one real early way of detecting lack of liver performance is detecting insulin resistance or a reduction in insulin sensitivity, right? And hepatic insulin resistance is the earliest form of insulin resistance. It occurs before you see peripheral insulin resistance, right? The liver often will show this early sign of metabolic inflexibility and glucose overproduction before you see it in any other systems, in any other tests, right? And so this is why clinical biomarkers such as the ones listed below are going to be more important than the existing conventional markers used to measure insulin sensitivity or risk for prediabetes and diabetes, right? So what you want to track is fasting insulin, right? And you want to track your triglyceride to HDL ratio, right? And we'll talk about why triglyceride to HDL ratio. That matters quite a bit. You want to look at HOMA-IR. HOMA-IR is a really, really important early hepatic insulin resistance marker. Right now, HOMA-IR is basically the ratio between fasting insulin and fasting glucose, right? So if you look at, so conventionally what people would do is they would look at fasting blood glucose and they would look at A1C, right? If you have elevation in fasting blood glucose, if it's over 100, or you have an A1C of 5.6 or above, I don't know if the units are different in the UK, but in the US, based on the units that we use here, the threshold for problematic fasting insulin is above 100, and the threshold for A1C is 5.6 or above. And 5.6 to I think 6.5 is considered pre-diabetes. 6.5 and above is considered diabetes, and that adjusts from time to time depending on the recommendations from the governing bodies. But that is normally what is viewed or looked at to understand insulin resistance or the risk of insulin resistance. The thing is, somebody could be insulin resistant by quite a measure for some time before you see it in fasting glucose or you see it in A1C, right? Because A1C is really looking at glucose and glucose levels. In lieu of that, looking at insulin response is actually even more important. And that's what HOMA-IR tells you, because HOMA-IR is the ratio between fasting insulin and fasting glucose, right? If fasting insulin is high, right? So in our case, our units, like if you are above, I think it's 6.5, 7. If fasting insulin is high and fasting glucose is normal, and you look at the ratio of fasting insulin to fasting glucose, if that ratio is above 1.5, it indicates strongly that that individual is insulin resistant. What that means is that individual can maintain normal physiological levels of glucose. So their fasting glucose looks okay. It could be in the 80s or 90s. It looks okay, but the insulin response is really high, right? Meaning they are overproducing insulin to manage the glucose. And they have to overproduce insulin because insulin sensitivity is going down, right? So HOMA-IR is a much better indicator of early stages of insulin resistance and looking at fasting glucose and A1C, because fasting glucose and A1C are downstream lagging indicators of insulin resistance. So to really understand if the liver is underperforming, and if the liver, and one of the early impacts of underperformance of the liver is insulin resistance, you want to look at HOMA-IR, right? Now, usually concurrently, and it's not always true, but concurrently with HOMA-IR indicating insulin resistance, meaning fasting insulin being elevated, your TG to HDL ratio is also going to be off, right? Because the liver produces HDL, the high density lipopolysaccharides. Lipoproteins. High density lipoproteins produced by the liver, and then TG's triglyceride also produced by the liver. If the liver is producing more triglycerides than HDL, what that indicates is that the liver is undergoing metabolic stress, right? Because the production of triglycerides is a result of having lower levels of beta oxidation, which is fat metabolism. That means there are too many calories coming in, and or the liver is reducing in its performance in metabolizing fat appropriately. And as a result, it packages lipids that come from as dietary fat into triglycerides and releases triglycerides, right, in order to be stored and utilized as energy. But an elevation of triglycerides, we know, is a metabolic signal of dysfunction, right? So if the liver is producing more triglycerides than HDL, it indicates that it is underperforming, it's under stress, and it's especially under metabolic stress, right? So often the elevated TG-HDL ratio goes concurrently with HOMA-IR, and fasting insulin is also often elevated. So I would say for a lot of your patients, as they're coming in, if they have anything metabolically related, right? If they have a little bit of excessive weight, especially visceral fat or fat around the midsection, if they are, just from your perception alone, metabolically unhealthy, if they have digestive issues, like if they bloat a lot, have SIBO, all of those things can be also further driven, and I'll explain how SIBO and barrier dysfunction and all that can be further driven by liver underperformance. But what you want to check in most of them is where are they with their liver performance, and one of the earliest detection of liver's underperformance is through hepatic insulin model or hepatic insulin function and hepatic insulin resistance, right? So hopefully that made sense. Now, lipid homeostasis, I already touched on this a little bit. The beta oxidation is lipid balance, right? That is, beta oxidation is the pathway in which fat is metabolized. And efficient mitochondrial and peroxisomal lipid processing will prevent hepatic fat accumulation. So if the liver can actually metabolize fat effectively in the mitochondria and outside of the mitochondria as well, you won't get fat accumulation and you won't get steatosis or fatty liver. Fatty liver is an end stage indicator of dysfunction in beta oxidation, but earlier stages of understanding dysfunction in lipid homeostasis as driven by the liver is the presence of excessive VLDL, right? Very low density lipoproteins. VLDL is an indicator that beta oxidation is overwhelmed, that lipid metabolization by the liver is underperforming. So then the liver pushes triglycerides out, and it'll push triglycerides out through VLDL, right? And these VLDL particles will have something called ApoB, which is a protein that wraps around it. And ApoB allows you to measure the particle number of VLDL, right? So you'll have elevation of ApoB and triglycerides in this case. So you'll have VLDL ApoB particles. And if you're not familiar with the difference between the two, you can have some LDL particles that are not ApoB, and you also when you're looking at LDL from a serum analysis, you're not actually looking at a true particle count. And the particle count is really important. And so looking at ApoB actually gives you a much better picture of the true particle count, because every VLDL particle has one ApoB, right? And so looking at ApoB as a measure of the presence of VLDL is a good way of looking at it. And then you can also assess it in conjunction with triglycerides. Now, with VLDL, of course, then you need a lipid fraction, right? Because you're going to capture VLDL in a total LDL assessment of serum. So if you can, I would also run a lipid fraction so that you could tease out the VLDL, because somebody could have a normal LDL level, right? We use milligrams per deciliter. So in that case, it'd be under 100 milligrams per deciliter. And as a result of that, and I think in the UK, you use nanograms. And I'm not sure off the top of my head how you convert that, but milligrams per deciliter under 100 is now established as kind of the normal range. And if you're below 100, you're fine. The problem is for early insulin resistance and indication of beta oxidation dysfunction, you will have normal total LDL, but the preponderance of LDL will be in the VLDL form, right? And that can be measured in particle number by looking at ApoB VLDL, right? And so it becomes important. So even though the patient, like let's say you have somebody comes in and they are a perimenopause woman whose body is changing significantly, experiencing all of these metabolic and hormonal and cognitive changes and all that, and you want to assess liver function, but you're not too concerned about heart disease, you may completely skip a cholesterol panel, right? But I wouldn't necessarily do a cholesterol panel with the view of heart disease. Maybe you would, because heart disease risk does increase quite dramatically in women in the perimenopausal age. But what I would look at is really the cholesterol fraction. I would look at the LDL fraction to understand if there's an elevation in VLDL particles. So it'll give you a pattern assessment of their LDL cholesterol, showing that the pattern is pattern A, pattern B, and pattern C is how most of the labs will denote it. it'll indicate that a high degree of the VLDL particles, a high degree of the LDL particles are in the VLDL form, and then that can be directly measured as ApoB particles as well. That indicates, along with elevation in triglyceride, along with elevation in fasting insulin, and looking at HOMA IR, it gives you a full metabolic picture that this individual is in early stages, but significant metabolic instability and lack of flexibility, right? This is the early stage in which diet and supplementation and lifestyle can really make a significant impact, right? So things like choline, for example, choline supports VLDL packaging. So choline is required for phosphatidylcholine synthesis, which is then a critical step in VLDL particle assembly and lipid oxidation. And then carnitine also enables fatty acid entry. So if this individual is dealing with beta oxidation, they may number one, look at reducing fat intake. And as a result of reducing fat intake, they can, on top of that, add in choline and or phosphatidylcholine and carnitine as well to support more absorption of the lipids and enhancement of beta oxidation, right? So that you could support the liver in dealing with the increased presence of lipids that they can't metabolize. So diet and supplementation, so both nutrients that are found in eggs, meat, supplementation may be useful in these targeted metabolic cases, right? And so this is the stage to start to do early intervention. And I would absolutely look at these markers in patients that are that you're not concerned about diabetes just yet, you're not concerned about heart disease just yet, but they're having issues with anxiety, they're having issues with hormonal imbalances. Maybe they're having some early metabolic issues like some fat accumulation around the midsection. They're having brain fog or gut-like issues. You want to use early detection of liver performance in a way as an assessment for what could be part of their foundational driver of those issues. VLDL, triglycerides, ApoB, GGT can also be used because GGT is an early detector of liver damage, although I wouldn't expect at early stages of insulin resistance that GGT would be elevated, but it is something you could look at as well. Another condition that is really important that occurs in a vast majority of adults is this impact of leaky gut. And the impact of leaky gut, the downstream impact is called metabolic endotoxemia, right? So the liver plays a very significant role in protecting the body from the negative effects of metabolic endotoxemia. And I'll talk about what that is. And this is another area in which you can assess liver performance. And we'll talk about all the conditions that are impacted by metabolic endotoxemia and how they are impacted by that and why the liver plays such an important role in protecting us from the effects of metabolic endotoxemia. So when you see some of these conditions that I'll show you that are impacted by metabolic endotoxemia, assessing the liver and liver's performance becomes critically important because the liver plays the largest role in trying to protect us from metabolic endotoxemia. So what is metabolic endotoxemia? Well, metabolic endotoxemia is characterized by increased serum endotoxin levels, right? And the endotoxin of interest here is LPS, lipopolysaccharide. The way it's measured in research, and I've published a couple of papers on metabolic endotoxemia, the way it's measured in research is you give somebody a high-fat, high-caloric meal in a fasted state, and then you're looking for a 5-hour mark of postprandial endotoxin increase in circulation, right? So you're looking for LPS specifically, lipopolysaccharide. Now, if you remember, lipopolysaccharide is a cell membrane component of gram-negative bacteria. Gram-negative bacteria are bacteria that don't have a cell wall, and instead they have this transmembrane molecule called LPS, lipopolysaccharide. LPS is an interesting molecule in that it has a lipid tail and a carbohydrate head. It actually looks very similar to our own lipid bilayers. So in the body, it's incredibly pervasive in that it can enter virtually every tissue. It crosses the blood-brain barrier. It crosses the myocardium. It enters into virtually every tissue, into the joints, into everywhere, right? Even the back of your eyeballs, it can enter. And anywhere it goes, it elicits a massive inflammatory response. The innate immune system activates a subclinical but persistent chronic low-grade inflammatory response to the presence of circulating endotoxins, right? Now, the reason for that is because your body uses measures of endotoxins, which is essentially a way of detecting gram-negative bacteria. It measures the presence of endotoxins as a signal of potential sepsis or bacteremia. So it takes it very seriously, right? You get dendritic cells and macrophages that activate in the presence of LPS. They release NF-kappa B. And as a result of that, the release of NF-kappa B, you get release of chemokines and all of these pro-inflammatory interleukins as well, which means that you get a massive recruitment of innate immune actors to the region where the LPS was. So if LPS leaks through the lining of the gut, ends up in circulation, and ends up, say, in your joints, right? You're going to get chemokine-based taxis of innate immune actors to that joint, dramatically increasing inflammation in the joint. You add to that mechanical stress of the joint, and you're going to start getting an anabolic catabolic shift in the joint where you increase the catabolic function rather than the anabolic function, which means you're going to start to see breakdown of soft tissue in the joint, like cartilage. Right, cartilage. So this is just a bit of a tangent, but I think it's important to understand this. So chondrocytes, which are the cells that lay down collagen to build cartilage, they are anabolic cells by nature in that they rebuild cartilage all the time. But in the presence of inflammation, especially IL-6, TNF-alpha, IL-1, which are all increased by the presence of LPS, those chondrocytes shift from an anabolic conformation to a catabolic conformation where they not only stop building cartilage, but they release enzymes like MMPs to actually break down cartilage, right? So there are numerous cells throughout your body, your myocytes in your muscles. You've got neurological blastoma cells in your neurons. You've got these types of cells, anabolic cells throughout the body that are designed to rebuild and repair systems, but in the presence of inflammatory mediators, especially IL-6, IL-1, and TNF-alpha, they conformation switch from anabolic cells to catabolic cells, and they start degenerating the tissue that they're supposed to rebuild. This is why the presence of endotoxins in the body, in circulation, is a massive risk for chronic conditions because they drive dysfunction and degeneration in whatever tissue region it lands. There's other things that it does as well, which I'll touch on in an upcoming slide, but just keep that in mind. That is one of the foundational issues with chronic low-grade inflammation, right? Everyone has heard that chronic low-grade inflammation is a foundation of disease. Why is that? Well, one of the reasons is because chronic low-grade inflammation, as marked by an elevation in IL-6, IL-1, NF-kappa B, interferon gamma, and so on, those chronic inflammatory mediators will phase shift anabolic cells to catabolic cells, right? So your body goes into catabolic mode and degeneration mode rather than being able to repair and rejuvenate. So that is why you start to see so many organ system and tissue dysfunctions in the presence of chronic low-grade inflammation. And the liver plays a very important role in how much endotoxin can end up in circulation, right? So understanding endotoxemia starts with barrier dysfunction. So your tight junctions become dysfunctional, your mucosa becomes dysfunctional, and even prior to that, it's dysbiosis. It's a change in the microbial environment that regulates the tight junctions and mucosal production. So the gut barrier becomes dysfunctional. You get an increased translocation of LPS from gram-negative bacteria. That LPS enters into enterohepatic circulation and makes its way to the liver, right? And then it becomes, and if it makes its way to the liver and it can escape the liver and more of it ends up in circulation, these are all the conditions that are very clearly shown to be heavily driven by the presence of LPS endotoxins, right? We're talking about obesity, insulin resistance, for example, type 2 diabetes. Even the American Diabetic Association published a study in 2017, I think it was, showing that the primary insult that sets the stage for the development of pancreatic type 2 diabetes is an inflammatory insult from the presence of endotoxins, right? Again, chronic low-grade driven endotoxemia. That is the mechanism here. NAFLD and NASH, so non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, also driven by elevation in LPS, right? Liver dysfunction can be driven by LPS, but it is the liver's job to protect us from LPS. Again, I'll explain that. Atherosclerosis, we also know CVD risk dramatically increased by the presence of LPS. Arterial stiffness, vascular dysfunction, so even vascular calcification can be driven by LPS, heart failure, neurodegeneration, Alzheimer's, and Parkinson's, right? There's a study in 2017, funny enough, there was a bit of a landmark study in Alzheimer's that showed that in individuals with Alzheimer's, they were able to enrich from the perinuclear regions of the Alzheimer brain gut-derived endotoxins, right? So the perinuclear region of the Alzheimer's brain is where you start to see all this protein misfolding, neurodegeneration occur, and so on. But all of that is mediated by inflammation in the brain. The question always was, what is driving the inflammation in the brain to start this process of tissue degeneration? One of the things that they found was the accumulation of gut-derived LPS endotoxins, right? So if LPS escapes the liver and ends up in circulation and it gets its way across the blood-brain barrier and accumulates in the brain, it can drive inflammation in the brain that can start the process of neurodegeneration. Breast cancer and tumor progression, again, inflammation, subclinical LPS levels found in metabolic endotoxemia enhances malignant phenotypes, right, and accelerates tumor progression. Inflammatory bowel disease, intestinal permeability, alcohol-associated liver damage, acute pancreatitis, allergic even rhinitis, airway inflammation, right? All of these conditions are driven by metabolic endotoxemia. In fact, I was asked to write a chapter, I don't know if you could actually see this, in Springer Health, in a reference textbook that came out a couple years ago on metabolic endotoxemia. And I have 6 pages of references on it, and there's about 40 references per page. So there's a lot of research on metabolic endotoxemia and its impact. So it's something we really have to pay attention to, right? Dysbiosis becomes this key source of inflammation, right? So a lower diversity in the gut microbiome, low levels of keystone species, and low levels of short-chain fatty acid production are the key markers of dysfunction in the gut that starts to create the risk of barrier dysfunction, which will lead to endotoxemia, right? And that endotoxemia means that LPS is translocating across the barrier and making its way into circulation, but first into enterohepatic circulation, right? So the blood that flows from the intestines will contain all of these compounds. So it'll also contain contaminants like phenols and acetaldehydes and ammonia, but it also contains LPS, right? And LPS is one of the most potent immune stimulators in the body. So then the liver cells, the lymphocytes, the macrophages, the dendritic cells, and natural killer cells in the liver have to respond to the presence of LPS that's coming in, right? And this occurs through toll-like receptor binding in the liver itself, in the hepatocytes. And then if there's too much of LPS binding toll-like receptors in liver cells, you start to get too much inflammation and damage to the liver itself, right? But, and we know that the liver that LPS does create liver damage eventually, right? So lipopolysaccharides, there's a couple examples here of papers that have shown this. Lipopolysaccharides in liver injury, the molecular mechanism behind Kupffer cells, and the activation of the Kupffer cells, which are the ones that have to deal with the presence of LPS. We also know that elevated endotoxin levels are present in non-alcoholic fatty liver disease. And then there's papers that show the role of gut-derived lipopolysaccharides and the intestinal barrier in fatty liver disease. And then also this schematic here shows that endotoxin levels, and this is derived from one of the publications from Hart and Allison et al. in 2010, where they showed that endotoxin levels were considerably increased in non-alcoholic fatty liver disease patients, and they saw a marked increase noted in early stage fibrosis compared with controls, right? So those results then interestingly will suggest that elevated endotoxins may serve as an early indicator of potential liver damage, and perhaps negating the need for invasive biopsies. So looking at LPS instead of liver biopsy to predict liver damage. So LPS coming through from the gut is incredibly damaging to the liver, right? And plays a significant role in the progression of liver disease itself. And when liver is dysfunctional, you're going to get insulin resistance, metabolic dysfunction, hormone dysfunction, brain dysfunctions, and all that. And so early liver performance becomes so important, right? Because some of this damage can then spill over to further gut dysfunction, right? When you start to look at SIBO and liver disease, right? So this systemic review and meta-analysis shows that the prevalence of small intestinal bacterial overgrowth in chronic liver disease is incredibly high, right? So they concluded, and I'll quote here what the paper said, SIBO is significantly more frequent in chronic liver disease patients as compared with controls. The association of SIBO and chronic liver disease was not confined to patients with advanced chronic liver disease, right? And this then suggests that SIBO is not a consequence of advanced liver disease, but may play a role in progression of chronic liver disease, which means that gut dysbiosis further drives liver disease, right? And then if you look at SIBO, leaky gut, and liver disease, right, there's more papers on this. Small intestinal bacterial overgrowth is associated with non-alcoholic fatty liver disease. They concluded the main finding of the studies are that both intestinal permeability, right, so which leads to endotoxemia, and the presence and the prevalence of small intestinal bacterial overgrowth are increased in patients with NAFLD and correlate with severity of steatosis. Now, why SIBO in particular? Well, there's another component here. So the small bowel naturally has more gram-positive bacteria. A healthy small bowel has a predominance of gram-positive bacteria, which means they don't have LPS. A SIBO gut has had a taxa shift where there's a dominance of gram-negative bacteria, right? And these microbes are coming in from various sources. They're coming in from contaminated food. They're coming in from poor oral hygiene. So you have a lot of enterococcus and E. coli and all that in the mouth. It's coming in from fecal oral contamination. And it's also in some cases escaping up from the large bowel if you have a issue with your ileocecal valve, right? So if the one-way valve is dysfunctional, you can get leaking up from the cecum back into the ileum of gram-negative microbes, which gram-negative microbes tend to be more predominant in the large intestine than the small intestine. So there's a taxa shift towards gram-negatives in the small bowel. And as a result of that, you end up with more LPS being produced in the small bowel. And if the small bowel is leaky, you're going to get a higher amount of LPS toxins leaking through and ending up in the liver in enterohepatic circulation, right? And as a result of that, you're going to drive more toxicity and inflammation and damage in the liver. So these are all connected. Now, I'll also talk about where SIBO may come from and how the liver may play a role in it to begin with, right? So, or at least increase the progression and severity of SIBO, right? But what's important to know is that the liver has inherent mechanisms to protect itself and us from the effects of LPS, right? And that is called HDL3. HDL3 is high-density lipoprotein, which is a form of HDL, but HDL3 is a derivative of it, and it specifically binds to lipopolysaccharide, right? And delivers it to these Kupffer cells for clearance and lowering systemic inflammation. So low levels of HDL3 equals high inflammatory load in the individual because deficient HDL3 will increase gut-derived endotoxemia, which means it's in the blood, which then contributes to metabolic endotoxemia, metabolic dysfunction, and immune dysregulation as well, right? So a therapeutic target here is interventions that aim to reduce LPS translocation, so fixing the gut, right? And supporting HDL3 function via gut health and metabolic optimization can be incredibly important, right? So think about in a healthy normal situation. In a healthy normal situation, you've got a predominance of gram-positive bacteria in the small bowel, so you're not generating a lot of LPS to begin with, but some LPS will leak through anyway, right? And also some will leak through in your oral cavity because you do have gram-negative microbes sitting in the gums. And as a result of gram-negative microbes sitting in the gums, you're going to get an escape of LPS directly in the oral cavity into circulation. But that circulation will also go through the liver at some point, and the liver will be able to neutralize all of this LPS coming through with HDL3. But let's assume liver health starts to become dysfunctional, right? Performance of the liver starts to become dysfunctional. So now the liver is not producing as much HDL3. Another indicator that the liver is not producing enough HDL3 is that the liver is not producing enough bile, right? One effect of lower performance of the liver is bile production reduces, right? So you got lower bile, lower HDL3. As a result of lower bile, you get an increase in gram-negative bacteria growth in the small intestine, because bile not only is it's not just a surfactant, it's not just an emulsifier, it is a signaling molecule, it is also an antimicrobial, right? So bile prevents overgrowth of bacteria in the small bowel. When you have insufficient bile, you actually end up having an increase in growth of bacteria in the small bowel. Now, bile and secondary bile salts also trigger the FXR, right, which is a nuclear FXR receptor, which I'll talk about and give a little more detail on in an upcoming slide. But one of the functions of FXR is to increase the production of antimicrobials by the small bowel enterocytes. And as a result, that reduces overgrowth of bacteria. So you could see that if the liver starts underperforming and it's not producing enough HDL3 and it's not producing enough bile, you're going to start to get an increase in bacterial growth in the small intestine. And as a result of that, you'll start to see a shift in having a predominance of gram-negative bacteria, because the gram-negative bacteria is coming in through the oral cavity, through fecal oral contamination, and so on. And without all that antimicrobial support of bile and the FXR activation, it allows for gram-negative growth, right? And so the gram-negatives start to increase, more LPS starts to translocate, and more LPS starts to go towards the liver. But because the liver is already underperforming and not making enough HDL3, it's not neutralizing the LPS effectively. As a result, the LPS causes liver inflammation and damage. As a result of that, it produces even less bile, and in turn increases SIBO and more LPS generation in the gut. That more LPS generation means higher amounts of LPS translocating, impacting the liver even more, reducing the bile and other performances of the liver, thereby then starting hepatoinsulin resistance and all the other dysfunctions that we could talk about, right? So you can see this enterohepatic loop, how it feeds back on one another. And if the liver continues to underperform, everything gets worse, right? Hopefully that was clear. I know there's a lot to absorb there. And so this speaks towards the gut-liver axis, right? Which refers to this complex bidirectional relationship between the gastrointestinal tract and liver. And that's characterized between this communication with the gut and the microbiome, right? And the liver through all of these pathways. So portal circulation is 75% of all liver's blood supply, which is rich in metabolites and nutrients, and LPS, if your gut is leaky, ends up in the liver. Bile acid production and modification of bile acids is really important. The modification of bile acids is done by the microbes, healthy microbes in the gut, and this is crucial for fat digestion and absorption, but also bile acids acting as a signaling molecule that impact motility, microbial composition through FXR activation, and then, of course, metabolic health through insulin resistance and sensitivity. The gastrointestinal microbiome will also interact with bile acids and other liver-derived substances, and all of this will influence liver function in general, and then production of these inflammatory mediators through a dysbiotic microbiome and also increased permeability will lead to more gut permeability and more damage to the liver, right? Through that loop that I talked about. And then all of this disrupts metabolic signaling because hormones and peptides like GLP-1, GIP, PYY, CCK, all of these metabolic hormones exert influence over the liver, while bile acids and liver metabolites govern the creation of these hormones in the gut, right? So these metabolic hormones are governed in part by liver metabolites, and then they themselves have an influence on the liver. And that is another part of the feedback loop between the gut-liver axis, right? So this enterohepatic circulation, let's talk about that for a second. I promised to elaborate on the FXR, FGF19, and TGR5 signaling. So really what we're talking about here is this bile acid FXR TGR5 pathway, right? So what happens here is you've got bile acid transformation. So primary bile acids that are synthesized in the liver are converted to secondary bile acids by gut microbes, right? And those secondary bile acids, a small percentage of them, about 5 to 10% of it, will go on to the large bowel. And in the large bowel, they'll actually act as antimicrobials to prevent the growth of opportunistic pathogens like C. diff, right? But the majority of it, 95, 90%, gets reabsorbed in the ileum, right? And it feeds the FXR FGF19 feedback loop, right? So the FXR activation in the ileum will induce this protein called FGF19, which feeds back to the liver to downregulate bile synthesis, right? So this is the feedback loop for bile regulation. But FXR does more than that, right? So it's located in the liver, this nuclear receptor. It's called the farneside X receptor. It's located in the liver, but it's also located in the small intestine and the ileum. It regulates bile acid synthesis by feedback loop to CYP7A1, right? So that's one of its functions, but it also improves lipid and glucose metabolism. So it plays an important role in increasing insulin sensitivity, lowering triglycerides, and enhancing HDL production and function, right? Including HDL3. So we could see how important this, the activation of the FXR, the farneside nuclear receptor is in metabolic health, in insulin resistance, and in HDL production, which HDL3 is part of that to neutralize LPS. It also plays a role in maintenance of intestinal barrier and does play a role in reducing inflammation as well, because the FXR activation will strengthen tight junction proteins and lowers gut-derived endotoxin leakage, right? So it plays a role in endotoxemia and barrier function. So you need primary bile acids for it, which get converted into secondary bile acids by the gut microbiome. And as a result, all of these effects I just mentioned are facilitated from those secondary bile acids, right? So now you can start to see that if gut becomes more dysbiotic, the liver function through FXR also starts to become dysfunctional. And as liver dysfunction accelerates, the gut becomes even more dysbiotic, right? They're interconnected. So this is a really important thing because FXR agonists are being now tried in massive clinical trials to treat non-alcoholic steatohepatitis, NAFLD, cholestasis, and metabolic syndrome because of how important this process is that is highly determined by liver function. Now, what about TGR5 signaling, right? So TGR5 is located in the enteroendocrine cells, in the brown adipose tissue as well. We know that as the healthy fat. It's also activated by secondary bile salts, which is the metabolic byproduct of primary bile salts. TGR5 activation in the intestines activates L cells to boost GLP-1. We all know how important GLP-1 is for enhancing insulin secretion and managing satiety, right? So another really important aspect of secondary bile salts, and an increase in energy expenditure as well, because in the brown adipose tissue and in muscle, it activates these D2, they're called deiodinase, which convert the T4. So that is part of the thyroid conversion, boosting mitochondrial metabolic function. So we know that thyroid function is the central command center of energy output. This is also regulated by liver health and the production of bile acids. And then it has anti-inflammatory function as well, because in macrophages, TGR5 activation will suppress NF-kappa B signaling and cytokine relief. So TGR plays such an important role. That's what's described here with its receptor functionality. So that in itself gives you a view on how important liver performance is in all of these functions. And a dysfunctional gut will cause liver performance issues, and liver performance issues will cause a further dysfunction in the gut. So it becomes important to intervene both in the liver and in the gut with any sort of gut dysfunction, right? Any sort of primary gut dysfunction. So testing gut liver function, what are some of the things you can look at? I would look at LBP. LBP is a protein made by the liver to bind LPS. It's called LPS binding protein. It's a great surrogate for understanding how much LPS is being produced and translocating, but it also will show you how much stress the liver is undergoing. In the stool, you can look at beta-glucuronidase. A dysfunctional gut microbiome will show an increase in beta-glucuronidase production. You also want to look at bile acids, because you don't want a dysfunctional liver will show lowered bile acids. And you can also consider zonulin, right? So zonulin it can be a marker of barrier dysfunction, but not on its own, because it's not been definitive in that zonulin moves when barrier dysfunction occurs, but as part of a total pattern, it can be helpful to understand, right? So overall, what you're looking for here is trends instead of these snapshots of any one of these biomarkers. Instead of these single data points, you want to evaluate the total picture, and this is the whole aspect of functional liver health, right? Understanding these connections, these feedback loops, how one thing affects the other when you start to look at biomarkers that indicate certain pathologies. You start to see a pattern in liver function, right? And retesting timelines, if you're doing some intervention, will be 8 to 12 weeks to monitor responses to gut liver therapies, right? Because if you do effective gut liver therapies, you should start to see a change in some of these biomarkers like LBP, like stool beta-glucuronidase, like bile acids, even zonulin. If you're using that, you should start to see changes in those in 2 to 3 months. What are some of the gut liver therapeutic levers you can pull? Diet first, right? High fiber, high resistant starch, and phenolic-rich diets will reduce LPS translocation and improve bile signaling as well. And then targeted gut support, you can use spore-based probiotics. We've done published studies showing that spore-based probiotics reduce endotoxemia significantly. We also have shown that prebiotics, especially oligosaccharides, dramatically increase the production of short-chain fatty acids, which play a really important role in protecting the liver and protecting the gut. Bitters, digestive bitters, enhance the activation of bitter receptors, which improve liver function and gallbladder function in releasing bile and improving bile flow and bile synthesis, right? And it modulates the microbiota as well and will help restore gut-liver communication. And then you want to address the barrier issue, right? So you want to treat SIBO, SIFO if that exists. And actually, a key treatment in SIBO, SIFO is treating the liver and improving bile function, because as I mentioned earlier, bile plays a very important role in managing overgrowth in the small intestine. Another aspect of SIBO that is often overlooked is stomach acid, right? So we know that reduced stomach acid increases the risk of SIBO. In fact, there's something called PPI-induced SIBO. The use of proton pump inhibitors dramatically increases the risk of SIBO. And why is that? Well, I mentioned earlier that a lot of the gram negatives that end up taking over in the small bowel come from your mouth, right? And come from the diet, from fecal oral contamination. So if your stomach acid is inadequate, those microbes are not dying in the stomach. They're instead getting into the small intestine in a viable state. And as a result, you're flooding the small intestine with gram-negative bacteria that then gives it a chance to take over that space, right? So you want to make sure that your stomach acid is adequate, and you can supplement with betaine HCl if they're producing inadequate stomach acid. Just quickly, detoxification is also managed by the liver. The liver, of course, helps clear estrogen through phase 1 and phase 2 detox pathways, and then the metabolization of hormones and even xenobiotics are dependent on the liver, and dysfunction in the liver can lead to estrogen dominance and fatigue that's caused by hormone dysregulation. And then thyroid hormone activation, I just talked about that mechanism, is also dependent on the liver in part, in conversion of T4 to T3, which then makes it really critical for metabolic regulation. And then sex hormone binding and clearance is also dependent on the liver, because the liver produces sex hormone binding protein or globulin that clears estrogen and androgen and cortisol via conjugation, right? And so phase 2 detox pathways are also, of course, controlled by the liver, and estrogens are cleared via glucuronidation and sulfation through phase 2 detox. So you need liver and you need the bile in order to have this hormone balance and proper clearance. And then microbial beta-glucuronidase will cause an increase in deconjugation of estrogen and a reabsorption of estrogen. So you want to make sure that the microbiome is also healthy. When you look at bile flow and hormone signaling, I've already gone through this with the FXR, FGF19, and TGR5. There's a continuous feedback loop on this, right? So cholestasis will disrupt this signaling and cause this impaired bile flow. And in fact, one of the issues with the microbiome being dysfunctional and not breaking down enough of the primary bile acids into secondary bile acids is you get an over absorption of primary bile acids, which floods the FXR receptor, causing a dramatic increase in the suppression of CYP7A1, which then reduces bile acid production quite dramatically. Right? So that's one of the side effects of that. So functional liver markers to look for here, key serum and urine markers includes SHBG, thyroid panel, of course, T3 to RT3 ratios, looking at the Dutch estrogen metabolites, right? Estrogen metabolites through the detox pathways tells you a lot about which of the pathways in the liver is dysfunctional. All of that tells you hormone dynamics as well. Integrative interpretation of all of these, of course, no single marker defines dysfunction. You want to look at everything in the context, including symptoms, history, and other labs. And then targeted intervention will align with all of the treatments that you see. So there's no like isolated value that you want to go after. You want to optimize enteroendocrine hepatic resilience, right, overall. Quick thing on metabolism and the liver, cortisol metabolism in the liver. Cortisol activation enzymes occurs in the liver, right? So the liver regulates cortisol availability, converting active to inactive form. So dysregulation here can amplify systemic burden of chronic stress. And then the stress impairs gut barrier, and the gut barrier increases LPS translocation, right? So again, another connection between the liver, leaky gut, and the liver, right? So that's through the presence and availability of cortisol. So therapeutic support, lifestyle targets should look at deep hygiene, stress modulation, anti-inflammatory diets, and movement. So again, looking at the systems biology way of looking at this, if somebody has an overt activation of the HPA axis, meaning they've got anxiety, depression, they've got chronic anxiety and depression, what you really need to be looking at, in addition to the things you would already be doing, is what's happening with the liver and the gut, right? Because there is a connection there from chronic CRH activation, elevation in cortisol levels, and increase in LPS. In fact, serum LPS levels is one of the best predictors of the presence of anxiety and depression, right? So the liver plays a very important performance role here. And one thing I'll measure about the liver-gut communication is this issue of kynurenine and the elevation of kynurenine, because kynurenine modulates what happens to tryptophan, right? So tryptophan is supposed to be metabolized into serotonin and melatonin, but an elevation of inflammation and a dysregulation of kynurenine pathways will cause tryptophan to be metabolized into kynurenine and quinolinic acid, which are actually neurotoxic and increase the inflammatory burden, right? So you could start to look at how the liver function will actually disrupt tryptophan metabolism as well. NAFLD, we've already talked about the impact of the neurometabolic system, but the interventions that you could start to think about here are time-restricted eating, aerobic resistance training, and quality of sleep that has a big impact on liver function, brain function, and NAFLD. Targeted nutrition would be polyphenols, omega-3s, high fiber diets to modulate inflammation. And then you want to track the subjective and objective outcomes, like you want to pair cognitive symptoms tracking with functional biomarkers, right, to get this full 360-degree view. You have the slide so you can look at these functional liver biomarkers. So maybe start to incorporate some of these as part of your intake or assessment of patients beyond just liver enzymes, right? If you're trying to think about the liver, you want to look at some of these functional biomarkers. I've also given some optimal ranges, but realizing that the units for these ranges may be different between the UK and the US. And then the dietary framework, I think you're all nutritional therapists, you know this better than anyone else. It's about targeted inclusions of things like, focus on choline-rich, cruciferous, whole foods, reduce added sugars, increase fiber, and then circadian alignment plays a big role in all of this as well. With supplementations, you can look at NAC, glycine, omega-3s, phosphatidylcholine can improve detoxification pathways and fatty acid metabolism. Botanicals like silymarin, milk thistle, so dandelion root, ginger, turmeric, they all help the liver significantly in terms of repair. And then in that whole gut-liver axis, spore-based probiotics, prebiotics, bitters play an important role there. You can even supplement with ox bile and betaine HCl to improve some of those functions. So key takeaway, liver is central to systems biology. It influences hormones, detoxification, metabolism, mood, and cognition. Precision matters using data-rich biomarkers like we showed you, and looking at patterns over time and aligning it with symptom trends will give you opportunities for direct therapy and will adapt your plan towards those. And this goes beyond liver function tests and focus on these pathology aspects of the liver. And all of this will empower you through, education will help you help your patients understand the physiology and the connections here between their liver health and all of these systems to engage, in enhanced compliance with the patients as well. And I know I've gone way over time, and I apologize for that, but there's so much to talk about here. I opened a can of worms with all of this functional test. This is a way to reach me. This is my email. I'll welcome any direct emails if you have questions and any other questions about anything. And then also I engage directly on Instagram as well. So feel free to follow me there and send me DM. So apologies for going over. It's just a heavy topic.
No.